people who go into psych, they're weird people. Racial slurs at me, felt like I was gonna faint a couple times. All right, my friends, here is why I did not choose psychiatry as a specialty. If you guys are new to the series, I go over things I liked, things I didn't like, and then at the end, some advice as to whether or not you should pursue that specialty. And now this is a very subjective, personal take of the specialty for my interests, for my likes, for my biases. If you want something that is much more objective, then we have the So You Want to Be a Psychiatrist video on the Med School Insider channel right up here. And we work with experts in the field, including multiple psychiatrists, to make that video. So that is a much more objective and well-rounded video. All right, so things I like. The first thing would be direct impact on patients. At the end of the day, a lot of us want to be happy or at peace, have some kind of emotional state as a goal. And the beautiful thing about psychiatry is that you are working directly with people to work on their emotional states. You can see someone by improving their relationships, by increasing their stability, by improving their self-awareness. They can go from being at a very low point in their life to progressing to a state of wellness and happiness, and that, I think, is very rewarding. Second would be the holistic approach of psychiatry. And the word holistic is something that gets thrown around a lot, and I have to be careful when I use it because I think it gets misused, like when people talk about DO versus MD, DO being more holistic. Not really, it's literally just adding OMT, OMM to the MD curriculum. And I think both DO and MD has moved in the direction of being more holistic with their approaches to patient care. But here, what I'm talking about is not just the biological or the pathophysiological processes of a disease when a patient presents to you. You're going beyond the symptoms and the diseases. You're now looking at things like social causes and social factors, psychological, biological, and so on. And part of the appeal there is that it is this multifaceted, complex problem that you can't just easily solve by prescribing a medication. And if you like a complex problem, there's something appealing about that. You're going to be addressing social support systems, personal history, and life stressors, and that's going to give you additional depth to your care as well as a greater understanding of each patient you come across. Number three, which overlaps with the prior point, is intellectual challenge. With this higher degree of complexity, there is added intellectual challenge with it as well. There are many fields in medicine where it can feel somewhat algorithmic, and then you have to use that intellectual challenge and critical thinking for the more edge cases or the more unusual cases, but oftentimes it's like, okay, cool, the simple algorithm, let's just run through it for most of the bread and butter. Whereas with psychiatry, on a more regular basis, you need to use that critical thinking for the nuanced listening and interpretation skills. You can think of diagnosing mental health conditions requiring some level of detective work, detective skills. You're exploring some underlying patterns and testing hypotheses. Number three is the flexibility and variety of the specialty. There's a wide range and diversity with work settings. You can do academia, community, private practice, community health centers, telemedicine, and so on. And this greater flexibility can allow for you to customize your career and lifestyle in the way that you want. There's a bit more intentionality there. To add to that, you can do your 8 to 5 Monday through Friday clinic, you can do your inpatient work, consults, partial hospitalization or IOP programs, and you can also differentiate these between patient populations if you want to go geriatric versus adolescent and so on. Now, I have heard some people say that if you want procedures, you can do TMS and ECT, which are getting more popular, but it depends on how much you enjoy procedures and what type of procedures you enjoy, because for someone that enjoys surgery, doing TMS and ECT are definitely not going to provide that level of stimulation and challenge and that fix for procedures that you may want. Number four is the potential for preventive work. In recent years, you guys on this channel have seen me getting more interested in preventive medicine for myself and my family in particular. And psych also handles this from a different perspective. It's not about doing CT angiograms and optimizing your blood sugar, but mental health is a very powerful lead domino that can result in many other things, not only mental health outcomes, but even physical outcomes, right? Someone who has depression is less likely to be able to commit to certain types of exercise or lifestyle habits that are going to improve their outcomes long-term. And actually, they're more likely to do those things that do not result in good long-term health outcomes. So there's a lot of powerful preventive work here. Psychotherapy can also be very effective for certain patients and for certain conditions whereby you're changing the way they think or view the world. And that can, again, have that very powerful lead domino effect without any of the side effects of pharmacologic intervention. Next is that it is an attainable specialty. It has been historically and continues to be one of the most attainable specialties. it is consistently in the number 3rd or number 4th least competitive spot. Now, in recent years, there's a lot of noise on the internet about how psychiatry is getting far more competitive. And you even hear people say that it's now a highly competitive specialty, which is just complete misinformation. It is not supported by any of the data. The only plausible reason I see right now for people arguing this point is that the match rate went from 92% to 89% in 1 year, and or NRMP charting outcomes over 2 years, I guess. And that is a decrease in match rate, but specialty competitiveness is not just about match rate, it's about other factors, and even 89 is still pretty high. I mean, derm, plastics, neurosurgery, which are the 3 top most competitive specialties, just to have some context here, are around 70. 68, 70, 73, that's very competitive. So 89 is not in the competitive range. And the other thing you have to keep in mind is year to year, most specialties have a trend upward trend with publications, right? Or with step scores, or various other factors that in isolation may have you believe the specialty is becoming more competitive, when in reality, if every specialty bumps up a little bit, your relative competitiveness doesn't actually change much, which is why psych has gone between 3rd and 4th least competitive. But the reason that I would like a specialty being more attainable and less competitive is because you don't have to kill yourself working so hard to then mash into that specialty. But if you are hardcore and you do want to work hard and really apply yourself and achieve the most that you can, then there's always the benefit of you work hard, you become the most competitive candidate, and then you get your choice of whatever residency you want to attend. So there's no real downside there. For those who want to explore the data objectively and see where specialties actually rank rather than just the chatter out there, then we have the Med School Insider's Specialty Competitiveness Index, which is linked below. And we use official NRMP data across, I think, 5 different factors. And you can see in one spreadsheet how everything ranks and how it compares. The last thing I like is the chill lifestyle. So if you want, you can work 9 to 5, no call, no weekends, no nights, and still make over $300,000. 309K is the average per Medscape's most recent data. That's not a bad gig. It is technically on the lower end. I think the average physician compensation is around 350K. So it's lower than average for physicians, but 309K is still great money, excellent money, and you're having a lifestyle that is way better than most physicians. So slight pay drop, but way better lifestyle and demand and stress, etc. And I have seen people in my own network that go into private practice, and then the ceiling for compensation is of course way higher, which you could argue is the case for many specialties. But it seems that with psych, it seems more common to go into private practice, just anecdotally from what I'm seeing, maybe because lower overhead or you don't have as much complexity to get a practice up and running, I'm guessing. But if I'm mistaken, and if you guys know more, then please do leave a comment below. All right, so things I did not like. The first thing would be ambiguity. I'm clearly a person that enjoys data, numbers, concrete facts, and certainty, and that's part of the reason I went into surgery, right? But with psych and with mental health conditions, even the diagnostic criteria is being updated every however many years with the DSM, right? We're now on DSM-5, I believe. So these mental health conditions don't have clear-cut and easily measurable symptoms or cutoffs, and diagnostic criteria, by definition, is highly subjective. So unlike cards or many other fields that are very concrete with numbers, you're looking at gray area. And this ambiguity can lead to frustration, because to effectively treat someone, you first need to correctly diagnose them. And if there's not complete certainty with a diagnosis, then your treatment modalities aren't going to be as effective. And I do think many of these issues will become better with time as we get a greater understanding of how the human brain works. But it's still, for the foreseeable future, will always be far more subjective and ambiguous compared to surgery or cardiology. And on a related note, you're oftentimes not getting to the root cause, the root issue of a mental health condition. You're more helping someone deal with a chronic mental health condition, which, if you want to be able to see a problem, fix a problem, and be happy to have solved that problem, then psychiatry isn't necessarily going to provide that. One thing that many people are surprised by is the fact that psych has a good amount of overlap with plastics. And I remember a program director telling me that she looked at psych grades first to see how someone would do in plastics, because she argued that psych is highly relevant to plastics. And I think she makes a great point, because whether you're going into aesthetic or reconstructive, there is a large degree of psych involved. Someone is mourning the loss of, if they have cancer, and you're doing a mastectomy with breast recon, there's definitely psych there. Or if you're doing aesthetic work, then there's oftentimes body dysmorphia and other personality clusters there. So knowing how to navigate these scenarios with a good appreciation and understanding of psychiatry is helpful. But I remember as a med student thinking that was my least favorite part of plastics, that psych component, where you want to help a patient, and those patients that aren't as complex from that psych perspective, they're going to be super grateful. You're going to feel like you truly helped them. It's rewarding. They're happy, you're happy. Whereas when the patient did have that more psych component, I found it to be personally more frustrating and less about the reasons I went into plastics, right? Now, related to ambiguity and data, because I wear a CGM and I do my CT angio and I measure my labs all the time, I've been doing meditation since, 2015, 2016, on and off. Sometimes I'm very consistent for months on end, sometimes less so. What's helped me get more consistent recently is being objective with my meditation. And I do think meditation, mindfulness, reflecting, journaling, those are all very helpful habits for me. And one thing that has allowed me to reapproach meditation in a way that feels more fun and allows me to quantify and see my progress over time is actually using some devices. So these are two separate devices that are not designed to work with each other, but my buddy from Plastics, one of my co-residents, he got super into mindfulness and spirituality and all that stuff. And he told me about his practice. So I actually got these devices after learning what he did. So the first is a Muse headband. And this is essentially a consumer grade EEG. You have a few contacts here. And then there's HeartMath Institute coherence tracker. So it's like you put it here to track your heart rate and your HRV. And he uses these two apps, which are not the official apps. Well, I can't show you because I'm recording on my phone right now. But he uses these two apps to track his brainwave state and his HRV. And the whole point is to have this immediate feedback loop. Again, you're now measuring something that is very subjective. Historically, this is all just, hey, how do you feel, etc. But now you can visually see when you're in alpha wave state, or when you're in a more relaxed state, when you're in greater coherence with your heart rhythm, and how your emotional state can change those. And it's helped me learn about how my thoughts or my feelings, and just telling yourself to feel happy or feel more at peace, or think of a time where you felt content or just warmth or love or whatever, and seeing how that influences your heart rate and your brain waves. That is very fascinating to me. So if you guys want me to cover this in a future video, then let me know with a comment down below. And if you want to try these devices for yourself, including those third-party apps that I use with them, then links are down in the description. Number two, the second thing I didn't like is the pace. It's a much, much slower pace in psychiatry compared to just about any other specialty. And for some people, like me, that can be boring. Now, I was reflecting on why that's the case, because with my friends and family, I love having those really deep, long conversations. You sit down, have a drink, have a meal, whatever, and you spend hours diving into like real shit. I remember even some friends of mine being like, hey, Kevin, do you talk to all your friends like this? And maybe, some friends are more open to that stuff than others. And I do enjoy those deeper conversations where you're getting to actual substance and not just talking about the Formula One race or, very superficial things. But I think it's different when it's your friends and family and you're doing it at a much lower frequency and doing it only occasionally. Whereas in psychiatry, if you're doing psychotherapy, you're having those longer conversations day in and day out. And they're 1 hour chunks, one after another. And you may enjoy some of them, you may not enjoy some of them, depending on the patient, the condition. That's probably why I love doing it with my friends and family. But when I was on my psych rotations, it did not feel fun, did not feel exciting. I think there's a balance between spending too little time and too much time with the patient. And everyone's gonna have a different point where they feel that balance is struck. So psych is very much on one extreme. And on the other extreme, you can have even PCP visits that are rushed 15 minutes back to back to back to back, sometimes even less than 15 minutes. And for me, psych is on the longer extreme of that. I would prefer something in the middle. And part of that also depends on how much, of course, face-to-face clinic time you want versus procedural time. And that's the whole conversation of surgery again. And the pace of surgery is clinic tends to be quick, but then most of your week, 3 days a week, you are in the operating room rather than clinic. And it can also feel somewhat repetitive if you're dealing with similar types of mental health conditions, let's say you've specialized, and it can feel like much of the same again and again. Number 3 is emotional toll. Now, when you're working closely with patients who have severe depression or trauma or other mental health conditions, you can experience compassion fatigue. Maintaining that professional boundary while also being empathetic and providing the best quality care is tricky, and it can be challenging and exhausting. And the risk of burnout increases with time. And from my experience in the hospital, I do think I would have higher risk of compassion fatigue. I remember a few instances, one time in neurosurgery where negative outcome for a patient, parents had their hopes up because they misunderstood and overheard the team rounding, and then they got crushed when in reality their child was likely going to be comatose indefinitely. That really weighed on me for the whole day. I remember I've never actually fainted, but I got very lightheaded and felt like I was going to faint a couple times. Both times was when a less experienced junior resident was doing a procedure on a patient very poorly, and the patient was very uncomfortable, and I started feeling extremely uneasy, and I had to excuse myself and sit down and got lightheaded. So I do think that for me, my personality, my beliefs, the way I view the world, etc., I would be at higher risk of that. I also felt like the inpatient wards for psychiatry during my rotations were just such a sad place to be. I did not feel excited going in, or when I left the rotation, I wasn't happy. It just felt like a kind of a downer of a place, which makes sense because oftentimes you're surrounded by and listening to sad people all day. And if you're able to do that and provide help to them, more power to you. But for certain people like myself, it can really weigh on us, and I don't think I would be in a happy place doing that day in and day out. Many people forget that to provide the best quality care, you need to be in a good mental state yourself. So choose the specialty and have the support systems that allow for that. Number 4, combative and aggressive patients. Oh boy, do I have a story here. So I did my rotation at a military base, and there are actually 2 things I learned from that. Let's start with the combative patient. There was one patient who was there for quite a while, and it became very uncomfortable and very unpleasant because, first of all, she would yell racial slurs at me, and she thought I was Hispanic, which, regardless of what I am, you shouldn't be yelling racial slurs, but she thought I was Hispanic and was yelling racial slurs, and also accusing me of doing some terrible acts, some heinous acts, with my group of other Hispanic friends or people against her at her home. It was really weird and just very uncomfortable. And then she would like start slamming the table and frothing at the mouth, yelling and point, like it was just really, really uncomfortable. And my preceptor, he was seemed more amused by it than anything, and I was like, I'm very uncomfortable. Now, psychiatrists, unsurprisingly, are at high risk of getting harmed by their patients. I think it's psychiatrists and EM docs that are the 2 highest risk. And it's not just the outwardly combative patients. I mean, imagine the person who's disgruntled and just waits for you to leave the hospital and get in your car and then follow you home. There's the likelihood of that, I feel, is much higher in psych than in just about any other specialty. That brings me to the next point, which is abuse of the system, which I saw again during this rotation, where a lot of people would want an honorable discharge from the military. And I didn't realize this was a common thing, but when I was on that rotation, literally more than half fell into this category. And I raised the concern with my preceptor, is, oh yeah, that's like totally normal. That's just kind of the name of the game, and based on our patient population and based on this practice, that's just what's going to happen. And it felt, I get a very icky feeling when people are abusing the system. And there's actually another story that I'll probably bring up in a different video of abuse of the system at a different hospital in a different rotation. But I guess growing up, I always assumed that people using these systems and these safety nets were using them for the right reasons. And as I've gotten older and had more exposure to various rotations, it's very much surprised me how frequently these safety nets are abused. Next up, mid-level scope creep. Mid-levels are going hard after primary care with the scope creep issue. And there's a spectrum, right? So I think their Dunning-Kruger is very powerful, but they know that they can't just become plastic surgeons or general surgeons or whatever surgeons, right? But psychiatry is definitely at a higher risk. So they're not going after it as hard as primary care, but it's essentially next in line kind of thing. You know, psych, internal medicine, anesthesiology, emergency medicine, psychiatry. There isn't really much to keep them out of a field like psychiatry. With surgery, again, there's that wider moat, and there are some limits to the Dunning-Kruger effect. But by the way, I'm not anti-mid-level. I'm anti those who are so deep in the Dunning-Kruger effect that they put others at risk, and through their delusions become aggressive about those who have better training, providing better care, and use very warped and flawed studies to try to prove their point. Next up, we got chill people, which is generally a good thing. But what I would argue is that in any specialty, you have to find your people. And I like that in psych, people are more relaxed on average, but people who go into psych, they're weird people. I'm a weird person, but I'm a different kind of weird. And I didn't have issues with the people that I met on psych, but I also didn't really gel and feel at home with the overall psych personality types. So being weird is good, but just find the specialty that has your kind of weird. Next up is the stigma around mental health. This is a smaller one for me because I've never felt as strong of that stigma compared to how people talk about it. I've never been hesitant or shy to go seek mental health services for myself when I needed it, and I don't judge others that do either. But in the US, there certainly is some level of stigma, higher or lower in various social circles and in various regions and cities. And while my personality type doesn't really care so much what colleagues or others may think of being a psychiatrist, what I think is more relevant to your immediate happiness and satisfaction is how patients feel about mental health, because that can change whether or not they pursue mental health services, and also their adherence, their compliance, whether they come back to see you in the future, and that can more directly impact your own satisfaction. Next up is medical knowledge usage. You go to med school, you do these 4 years, you learn so much about the human body and the pathophys and the physiology of all these different organ systems, and then in psychiatry, it feels like you don't use very much of it. And don't get me wrong, there are many other specialties, including plastics and ortho and whatever else, where you are quite narrowly focused, and that limitation bothers me in those other specialties too. Something like internal medicine, you get to use so much of it. Family medicine as well. Psychiatry, it just feels like you don't use most of it. And also tied into that with the ambiguity, it feels like a lot of the medications you're using, a lot of the therapies, assuming you're past psychotherapy and CBT and DBT and all those things, it's throwing medications at the wall based on what some farm companies discovered, and they were throwing stuff at the wall. They figured out kind of what stuck, and now it's your job to also throw these various combinations at the wall based on their findings and then see what sticks for your patient. It doesn't seem as based and grounded in a solid understanding of how the human mind works. I shouldn't say not a solid understanding, but not as solid of an understanding compared to other organ systems. Next is medication side effects and dependency issues. Psychotropic medications can be very powerful and life-changing in a good way, but they can also have quite significant side effects. And I'm not just talking about giving SSRIs to guys and having a lot of issues with libido.
And those are just the side effects they tell you about. I get the sweats, my bones are cold, my teeth are loose, my heart gets really, really hot. I could read minds. And sometimes I wake up driving a stolen car. When
you're managing medication dependency or even misuse, you also get into the murky areas of ethical dilemmas, and it's a position that is not fun for anyone. And lastly, patient compliance and engagement. Psych requires significant commitment from patients, whether that's therapy sessions, lifestyle changes, regular appointments. And when compliance or adherence suffers, then of course the treatment and the outcomes also significantly suffer. This is something that I found frustrating even in primary care clinic, where you spend so much time speaking with the patient and coaching them, and they agree, and you do your motivational interviewing, and then they come back 5 months, 6 months later, and you realize that their A1C or whatever it is hasn't improved at all. It seems that you can only do so much, but the ball's ultimately in their court. And for me, my personality, I want to see a problem, help solve that problem, and then be happy that that problem has been solved. Whereas here, there's a lot of this gray area, a lot of this back and forth, a lot of responsibility on the patient, and you can only do so much, which to me, incredibly frustrating to spend so much time and effort and feel like you really broke through with this patient. You even went above and beyond, spent extra time, went after hours. I'm going to really help this person out. And then at the end of the day, 6 months, a year later, nothing's really changed. If you're patient and you can be that person, more power to you. We need those people in the world. That's just not me. All right, so finally, should you choose psychiatry? I think psychiatry is so unique and so different from other specialties that you either love it or you hate it. There aren't as many people who are like, I like psych, but I also like emergency medicine and anesthesiology. They're all just so different. Psych is just so different from everything else that if you know, you know. If you have a passion for mental health, you have resilience or comfort with ambiguity and an empathetic but boundary conscious approach to patient care, then psychiatry might be a good fit for you. But also consider your preferences and proclivities with things like compassion fatigue, emotional intensity, adaptability, and comfort with more varied treatments. And of course, the slower pace, not only of the specialty, but also the slower pace of scientific advancement in the field. It's definitely not for everyone, but for the right person, psychiatry is going to be very fulfilling and rewarding career. My friends, let me know what specialty I should cover next in this Why I Didn't series, and I'll see you in that next one.